Ladies and gentlemen, welcome to the inaugural lecture of the Environmental Foundation Professorship in Thoracic Surgery by Professor Calvin Ng. Please rise for the entrance of the official procession. Please be seated. Good afternoon, ladies and gentlemen. My name is Elise Chang, a resident specialist. It is my honor to serve as your MC today. To begin with, please welcome Professor Dennis Lo, the Vice Chancellor and the President of the Chinese University of Hong Kong, to deliver a vote of thanks to the CUHK Environmental Protection Foundation. Professor Lo, please.
Dr. Colin Lam, Professor Calvin Ng, Professor Philip Chiu, colleagues and friends, ladies and gentlemen. So thank you very much for joining us at this momentous occasion to celebrate a remarkable milestone in the career of Professor Calvin Ng from CUHK's Faculty of Medicine. His inauguration as the Environmental Foundation Professor of Thoracic Surgery is a testament to his exemplary work in trailblazing minimally invasive approaches to managing thoracic diseases and malignancies. Today's inaugural lecture gives Professor Ng a precious opportunity to share with us his experiences in pursuing continuous breakthrough in medical research and how different encounters in life have played a role in propelling him to push for the frontiers of knowledge and bring practical benefits to human health. This meaningful event could not have been possible without the generosity of our esteemed donor. On behalf of CUHK, I'd like to express a sincere vote of thanks to the CUHK Environmental Protection Foundation Limited for its staunch support for our education and research endeavors. The establishment of the Environmental Foundation Professorship in Thoracic Surgery well demonstrates the philanthropic spirit of the foundation and its commitment to advancing scientific advancement for the well-being of humanity. We're deeply grateful to Dr. Colin Lam for coming to this inaugural ceremony. Dr. Lam, your presence speaks volumes about your heartfelt support for CUHK missions as a civic institution and your strong belief in the transformative power of education and research. The CUHK Environmental Protection Foundation Limited was established by the renowned philanthropist, the late Dr. Li Xiaoqi. Dr. Li, founder of Henderson Land Group and a legendary figure in the Hong Kong real estate industry, was an honorary doctorate and an honorary fellow of CUHK, as well as a former member of the Board of Trustees of United College. Over the years, the Li family has been passionately championing numerous public welfare initiatives in Hong Kong, the Chinese mainland, and around the world. Their goodwill has extended to the academic community as well. And like many other institutions in Hong Kong, CUHK is fortunate to have the opportunity to build close ties with the family and to receive the magnanimous gifts from them, which have enabled us to broaden our impact through various projects, from college development, campus enhancement, and academic programs to scholarships, awards, and the launch of research initiatives. The CUHK Environmental Protection Foundation has been faithfully reflecting the Li's family enduring devotion to the betterment of society through making substantial donation in support of different facets of societal progress in the local community and beyond. Now, we're particularly thankful to the Foundation for setting up this prestigious endowed professorship, enabling outstanding scholars and researchers at CUHK Faculty of Medicine to further the commitment in cutting-edge research in thoracic surgery, empowering the university to advance clinical excellence to pursue research innovation and stand at the forefront of this important field. So under auspices of the generous donation by the foundation, I'm sure Professor Ng will go on further along his path of scientific discovery to benefit more patients. Now, please allow me to extend my warmest congratulations to Professor Ng and thank Dr. Lam and the CUHK Environmental Protection Foundation once again for the abiding interest in supporting development of CUHK. So ladies and gentlemen, so may I wish you a most enjoyable time listening to this inaugural lecture. Thank you.
Thank you very much, Professor Lo. Now, may I please invite Professor Lo, accompanied by Professor Philip Chiu, Dean of Medicine, and Professor Calvin Ng, to present a certificate of appreciation to Dr. Colin Lam. Dr. Colin Lam, Professor Philip Chiu, and Professor Calvin Ng, please. Thank you all. Please be seated. Now, please welcome Professor Philip Chiu, Dean of Medicine, to introduce our distinguished speaker, Professor Calvin Ng. Professor Chiu, please.
Vice Chancellor Professor Dennis Lo, Dr. Colin Lam, guest and representative from the CUHK Environmental Protection Foundation, distinguished guests, esteemed colleagues, ladies and gentlemen, good evening. Thank you for joining us for this momentous occasion. It is my great pleasure to welcome you to the inaugural lecture of Professor Calvin Ng, endowed as the Environmental Foundation Professor in Thoracic Surgery. On behalf of Faculty of Medicine at the Chinese University of Hong Kong, I would like to express our heartfelt gratitude to the CUHK Environmental Protection Foundation for their generous support. This professorship is a meaningful recognition of Professor Ng's exceptional achievement and a powerful endorsement of our shared commitment in advancing thoracic surgery through clinical excellence, innovation, and education. Today, we celebrate not only a personal milestone in Professor Ng's career, but also the broader impact of his pioneering work on saving patients' lives, on leading education in thoracic surgery community, as well as on the transformational effect of minimally invasive thoracic surgery in Hong Kong and across the globe. Calvin's journey in medicine begins at the Imperial College London, when he graduated in 1999 with Bachelor of Science and Bachelor of Medicine and Surgery with first-class honor, distinction in surgery, and the prestigious Anthony de Rothschild Gold Medal for Surgery. So he has already been labeled as an outstanding surgeon at the very beginning. His surgical training took him to some of the world-leading institutions: St. Mary Hospital, London, under Lord Aradasi, Prince of Wales Hospital, Hong Kong, under Professor Anthony Yim, and Queen Elizabeth Hospital, Birmingham, under Professor Tim Grantham, Vice President of Royal College of Surgeons of Edinburgh. Professor Ng was awarded Fellow of the Royal College of Surgeons of Edinburgh in 2007, Doctorate of Medicine from University of London in 2008, and Fellow of the American College of Chest Physicians in 2009. He joined the Chinese University of Hong Kong as Associate Professor in 2014 and being promoted to Professor in 2019. Professor Ng is internationally recognized as a pioneer and world leader in minimal invasive approach in managing thoracic diseases and malignancy. In 2012, he first performed the uniport VATS lobectomy in Hong Kong, establishing himself as a pioneer in this technique in Asia-Pacific region. As a president of the Asia Association for Single-Port Thoracic Surgery and founder of the Asian Single-Port VATS Symposium, he has educated thousands of surgeons on this revolutionary technique over the past decade. His interest in image-guided surgery has perhaps had the most transformative impact on the global landscape of lung surgery. He performed the world's first hybrid operating theater image-guided uniport surgery in 2015 and image-guided electromagnetic navigation bronchoscopy in 2016, innovations that have brought about changes to international guidelines on small lung tumor and ground glass opacity management. I share a similar field with Calvin because I'm an esophageal surgeon. I need to push away the lung before I can reach the esophagus. But in fact, I don't recognize it's so important that the lung actually has the most important disease preferences like lung cancer, that Calvin transformed the management from maximal invasive to now non-invasive approach. Professor Ng's pioneering spirit continued to push boundaries. He has pioneered non-invasive transbronchial microwave ablation treatment for lung cancer and performed the world's first robotic bronchoscopic ablation in 2022. His renowned team now has the world's largest experience with this revolutionized non-invasive treatment for lung cancer. His trailblazing work continues to lead the world in the use of the third-generation robotic bronchoscopy system and innovative bronchoscopic therapeutic tools that provide novel, non-invasive treatment options for cancer patients. Beyond his clinical innovation, Calvin has made extraordinary academic contribution with more than 340 publications in prestigious journals, including The Lancet, Lancet Oncology, Journal of Clinical Oncology, achieving an H index of 44. He has authorized more than 30 book chapters in classic textbooks, such as Person Thoracic and Esophageal Surgery and the Shield Thoracic Surgery. Notably, Professor Ng is the corresponding editor for the Atlas of Uniport Video Assist for Bronchoscopic Surgery, which has become the first and standard text for uniport thoracic surgery worldwide. His leadership extends to numerous international societies, including International Association for Study of Lung Cancer, the International Society for Minimal Invasive Cardiothoracic Surgery, the European Society for Thoracic Surgeons, and the Asia Thoracic and Cardiothoracic Surgery Association, where he served as director and committee member. He also served as editor-in-chief, associate editor, and editorial board member of more than 15 scientific journals. Probably Calvin do not need to sleep. Professor Ng's excellence has been recognized through numerous awards, including European Association for Cardiothoracic Surgery Techno College Innovation Award in 2019, Diploma Innovations Geneva Bronze Award in 2021, and as a team leader for the New Territory East Cluster Lung Cancer Multidisciplinary Team Outstanding Team Award in 2021. His commitment to education is equally impressive. As a program director of Cardiothoracic Surgery Board of Hong Kong, he oversees training for the next generation of cardiothoracic surgical trainees. He also served as a council member of the Hong Kong Society of Echosonography and the Hong Kong Thoracic Society. What makes Calvin's story truly remarkable is not just the breadth of his innovation, but the depth of their impact. His work has fundamentally changed how we approach lung cancer treatment, making previously invasive procedure minimal invasive, and creating entirely new treatment options where none exists before. He has transformed not only surgical techniques, but also patients' outcome and quality of life. This evening, we look forward to hear from Professor Ng, sharing his insights on the evolution of thoracic surgery, the innovation that have shaped his career, and his vision for future of minimal invasive approach in treating thoracic diseases. It is a story of innovation, perseverance, and dedication to improve patients' care, and I'm confident that it will inspire all of us. So please join me in welcoming Professor Calvin Ng to deliver his inaugural lecture.
Thank you, Professor Chiu. May I please invite you and Professor Low to take your seats in the audience. Thank you.
Thank you very much indeed, Dean Philip Chiu, for the kind introduction, and dear Vice Chancellor, Professor Dennis Low, Dr. Colin Lam, representatives from Li Xiaoqi Environmental Protection Foundation, colleagues, friends, ladies and gentlemen. Thank you for attending the inaugural lecture for Environmental Foundation Professor of Thoracic Surgery, Chance Encounters Leading to Paradigm Shift in Thoracic Surgery. You shall find our story behind the turning points and I guess the lucky encounters that shaped my academic career development. So I guess with all stories, either good or bad, we must start somewhere. And that's me, Generation X, born in 1970s. Maybe you can decide in the lecture whether I fit into these descriptions that I got from the internet. Self-reliant, perhaps, willing to learn, skeptical, brand loyalty, definitely, CUHK, please take note. Like stable careers, please, thank you, yes, keep renewing my contract and being a bit cautious with my approach. So we all have ambitions in life, but I guess at that age that you can see there, it was mostly from my parents who decide or want me to do something in my life. My father is a family physician, so his ambition was for me to become a medical doctor, perhaps, as you can see from the number plate. However, it is possible that I misinterpret them. Now, as I go through my album when I was young, it's definitely a recurring theme that every vehicle that I was going on had that number plate on. But I don't really know whether it's the doctor that you want me to be, which I am now, or that I've misinterpreted you, Dad, and maybe you want me to be a managing director or even work at McDonald's. I am not sure about. But I most probably prefer to play than go into books when I was young. I was rather naughty. That's probably why I was sent away to boarding school very young, and books did put me to sleep. But I was very lucky. I had a very supportive sister I can rely on and look up to, as she also chose a career as a doctor, so a good role model for me. And of course, I have a glamorous and super mum who can do anything and everything that you can see there. But clearly, she also needs to be a bit of a tiger mum to help bring out our success, myself and my sister. And as for dads, well, they just had to work very hard, I guess, to make ends meet. And as there's a saying in Asian, culture, kids are like dinosaurs, devouring all the money from their dad. And I just added the blood there to add on the effect for this slide. So somehow I got into DPS. Probably my mum helped a lot, and spent my primary 1 and primary 2, 3 years in the DPS. You can have a guess where I am. I'm a little bit shy, standing at the back, and it's actually here at the top right there, yes. So that's me at the back, and in fact, next to me in the brown dress is Mrs. Julia Kwong, who's a maths teacher who I remember very well, and who've actually kept in touch with even up until now, so many years beyond that. I later went to Winchester College in UK, where great friendships were made, and some have found precious time today to come here to support me. As you can see, the school trained me, not just academically, but also the ability to tolerate alcoholic toxins, and that's essential for a successful academic career, by the way. The school motto you can see is, that you note on the motto is, "Manners maketh man." And this not meaning just having like table manners or putting chairs out for ladies, but actually has a deeper meaning of the manner in which you conduct yourself to have integrity, honor, and moral values. This was made actually famous by the film Kingsman, who used it to highlight their moral standards of their special agents. I entered Imperial College for my medical training. I failed to get into Oxford, sorry, Dad. Some of you may know that Alexander Fleming discovered antibiotics at St. Mary's, the penicillin, and also it was where all the royal babies were born, in fact. There I met an inspirational teacher, Professor Aradazi, who was chair of the surgery at that time when I was working for him, but would later become knighted and become a lord. Apart from his great skills, he showed compassion, modesty, vision, and leadership. He had great attention for detail, and interestingly, he actually offered me a job after I became sort of a junior a resident for him. And I actually politely declined, so I turned down a Lord in my career. What job did I take up instead? Well, through the email grapevine, actually, I heard that Professor Anthony Yim, Chief of CT Surgery at CUHK, at that time a relatively young faculty in terms of university terms, was looking for a clinical research assistant. So I actually came back to Hong Kong. I thought it was time. I'd always wanted to come back to Hong Kong to work and contribute. And it was time, after 15 years in UK, to return to Hong Kong. I actually came back to become a research assistant for 1 year before I found a job to be a resident. And of course, Professor Yim is an absolute pioneer and world-famous surgeon trained in all the great institutes of the world, Cambridge, Oxford, Mass General, etc., and wrote the first book on minimally invasive cardiothoracic surgery in the world. Another life mentor I wish to mention and acknowledge is Professor Song Wan, who is a world-famous cardiac surgeon with accolades from the world's most prestigious cardiothoracic societies. Apart from skills and attention to detail, he reinforced my belief in integrity and honor. I actually returned to the UK for 1 year during my higher surgical training, and to be with Professor Tim Graham, who later became the Vice President of the College of Surgeons of Edinburgh, made lasting friendships there, and many of the friends we've kept in touch up till this point. Now, after all the training is finished and acquired the necessary paperwork from the different colleges and institutions, you thank your mentors, and as you can imagine, you feel like an eager, young, hot-blooded surgeon ready to face the world, ready to contribute. So that was in the year 2008. So the year I finished training, in fact, 3-port VATS, performed through several keyholes that you can see there, was the standard of care that was set up by Professor Yim in our hospital, and we're able to manage most thoracic conditions, such as even major lung resection for lung cancer that you can see here. We showed under his leadership that having smaller wounds were associated with benefits, clinical benefits, less blood loss, less pain, more mobility, earlier discharge, less bleeding, less chest drain output, etc., etc. Any benefit you can think of, and it's kind of obvious when you compare the two techniques, one with a huge wound and one with keyhole wounds that you can see on the right. But I was also noticing that we were turning down patients with very big tumors. You can see in the top right there, that CT scan. And what can we do for these patients? I was just out of school, out of training at that time. After a few years actually studying, we pioneered the approach of titanium rib reconstruction of the chest wall. Because what we were afraid of to begin with was that once we removed that big tumor, we had nothing to cover that area. And you can see here that after the tumor is resected, there is a big gaping hole on the bottom left that was covered by neopleura and also titanium rib and soft tissue. Many patients were able to be extubated almost immediately after the surgery, and we performed the first cases in 2011. And in Hong Kong, we invented this technique. Following the first cases and publications, we generated more data, and we're actually able to contribute to the approval of this product for FDA approval, 510(k) approval, providing feedback to the modifications towards the product, and more recently published our excellent 10-year results, probably one of the longest with this product available. Furthermore, we felt that many more patients should benefit and could benefit, and therefore we conducted chest wall reconstruction conferences and workshops for surgeons throughout Asia in order to learn the technique. So far, thousands of patients have benefited from this approach. So top right there, big tumors we can now deal with, we can reconstruct the chest wall. But I take a step back and we look at the 3-port approach to minimal invasive surgery. Is there a room for improvement? Coincidentally, around that time, we had actually a visitor from UK, Dr. Kelvin Lau, who had just finished training, similar to my level at that time, and wanted to spend some time in our hospital to see some VATS surgery. But when I actually saw him, there was a very strange familiarity about him. I recall this face in my primary school. And he was there in primary 1 photo, on the right there. And oh my God, we are DPS brothers, you know. After missing, you know, each other for more than 15, 16 years, we are back together. And we're both thoracic surgeons. Can you believe it? Amazing. So around the same time, in fact, when Kelvin was here and I was here, sort of the two Kelvins and Kelvins, it was very confusing. In 2011, a Spanish surgeon reported performing lobectomy for lung cancer through a single VATS incision, not the standard 3-port VATS. I mean, that was big news, you know, small incision, 3-4 centimeters, and you can do big lung surgery with very quick recovery. Together with Kelvin, actually, so Kelvin and Kelvin combination, after careful planning, we conducted the first single-port VATS lobectomy in Hong Kong in May 2012. We found that there was a lot of instruments, collisions, great difficulty, suboptimal vision of the operating field. Well, we did complete the operation in just under 3 hours. But we thought that there was something, you know, some ways that we can do this in a better manner than what we were doing back then. So I actually emailed the Spanish surgeon, and this is really the screen cap from the email back in 2012. And basically, I said, can you give us some tips and tricks? Come to us. And he responded by offering to come to Hong Kong and do some workshop and also do some live surgery. And from this email, in fact, the Asian Single-Port VATS Symposium was born. For the first meeting, there were only a few attendees, you can imagine, with any new technique, a lot of doubt and resistance. But thankfully, we're actually able, with CUHK support, invite some of the fathers of innovation. First of all, Diego in the top left, and then the father of single-port VATS lung resection, Gaetano Rocco, who's now in New York, MSK, and also Thomas D'Amico, who is the father of 2-port VATS surgery of the chest, who is the chief of Duke University Thoracic Surgery. And friendships were made at that time. We came to the conclusion that there was certainly something in single-port VATS worth investigating and exploring further. Progress is impossible without change, and I think change can be uncomfortable and scary. But I've always been a bit fortunate. Immediately after the inaugural single-port VATS symposium, I was given the opportunity to present single-port technique in KATSO, which is a very prestigious Korean society meeting. You can imagine that many surgeons were skeptical and want to keep to traditional ways of doing things. But Tadasu Kono from Tokyo, a very senior and well-respected surgeon who is in the audience today and flew in from Tokyo, especially for this meeting, had the vision and the foresight to allow younger surgeons like myself to explore and to create change. So with the support from surgeons in Asia, this symposium grew from the first Asian single-port symposium in Hong Kong in 2013, second one in Korea, followed by return to Hong Kong subsequently with a very large number of delegates and faculty in the bottom right picture that you can see, and then followed by the fourth one really in Taipei and Shanghai and Manila, and subsequently in Japan, Nagoya, and the eighth one in Seoul this year after a short break because of the COVID. We understand that using one incision, one keyhole, may be less traumatic for the patient, but it's definitely more traumatic for the surgeon, and it's more technically demanding. We championed for this technique to be better defined and standardize the approach that we use, hence this paper describing where to put the instruments in such a confined incision. And we redefined how recent new endoscope designs can be used in single-port surgery to improve visibility and ergonomics during the surgery. We helped design, improve, and validate new endoscopic staplers in single-port surgery. This one with a narrower shaft that occupies less of the wound space, can be more angulated at the front, and it's shown to be equally safe. And we also showed that single-port surgery was less traumatic to the patient than multi-port VATS when we looked at certain blood biomarkers of stress and trauma. Numerous surgical societies in the West eventually warmed to the single-port approach a little bit. Perhaps one of the earliest consensus interest group in this procedure is the International Society for Minimally Invasive Cardiothoracic Surgery, And we looked at 145 studies of 88,000 patients of the different minimal invasive approach in terms of clinical outcomes, oncological outcomes, safety, and so on. And we conclude that single-port VATS did result in slightly less pain than multi-port VATS, but any minimal invasive surgery approach would be very appropriate for lung surgery at that time. With increasing global interest, I had an idea of putting together a book on this approach, a much more monumental task than I had actually anticipated, with hundreds of figures and videos to be inserted in the book. This brought together, however, the most advanced minimal invasive thoracic surgeons in the world, with friendships and connections going way beyond academia. As we progressed with our surgical techniques, I felt that the knowledge of the lung cancer in general public was quite poor. Thus, I decided to set up a registered charity with specific missions. One was to educate the public in talks and discussion groups, even during COVID via social media. And this was the Asian Association for Single-Port Thoracic Surgery. The mission of this charity extended to supporting healthcare professionals to participate in meeting and improve knowledge and skills to benefit patients. And occasionally, we get to share in the joy of those the charity supported in doing the research and development, in shining and receiving prizes and accolades at international conferences. So back to the landscape of lung surgery. We can now treat resectable lung tumors with single-port VATS with minimal invasive approach. Surely it's time for me to just chill out. It's done, right? What is more to do? Sadly, in the last decade or so, we are seeing something very strange. Presentation of more and more patients with tiny, small tumors or ground glass opacities, often many more than one, up to 15 or 20 I've seen in some of the cases. You can see on the left, far left, that yellow arrow pointing to a very faint spot in the left upper lobe of this patient. It is a big problem. And this is a changing trend that we see in the last 10, 15 years. Younger patients, patients who are non-smokers, we get asked constantly, why is this happening to me? I never smoked, no secondhand smoking. Earlier detection of patients having scans for their heart, but also able to pick up early tumors in the lung, and your health checks. So all of these contributing to finding these things, a lot of early multifocal lung cancers. So you can see on the right here, just two patients with just one cut of the CT with multifocal lung cancer, many primary lung cancers of different sizes, different stages of development. And the cause, probably, at least in part, related to air pollution maybe. It is that haze that sometimes you see out of your window or across the harbor that may be causing this, and the field change all over your lung. So we've always had air pollution, right, with factories and diesel cars in the past, taxis that are using diesel. So what has really changed? Maybe it's the size of the particulate in the air. The larger size ones, like the PM10 on the left-hand side, only manage to penetrate the big airways. But the smaller ones that we may be seeing these days, the PM2.5 and 1, are able to penetrate deep into the lungs and cause this generalized field change to develop into lung cancer. And the tiny ones actually go into the blood vessel and cause inflammation of your blood vessels, giving you stroke and heart attacks. The problem with small tumor is how do you get the diagnosis? For example, in the past is by sticking a needle into it from the outside to get some tumor cells for diagnosis. How do you hit such a small, tiny target? The other challenge actually is how do you localize it during the surgery? The small tumors cannot be seen or felt during surgery. At that time, many doctors actually suggested wait and watch. Wait until your cancer grows to 1 centimeter when we can get your diagnosis and we can find it during surgery. But to me, that was not the answer many patients wanted to hear. This is, I think, another one of my really lucky breaks, lucky chance encounters. So Covidien, a company that was later acquired by Medtronic at that time, decided to bring some of the more senior Asia surgeons to see some new technology called electromagnetic navigational bronchoscopy. I was fortunate to be invited by Professor Anthony Yim to tag along, really. And as you can see, I was certainly the most green and junior of all the surgeons around the table. But this also became a turning point when Anthony told me this technology is very important and a game changer. And I remember that sentence till now. So what is this technology? Basically, ENB system allows doctors to navigate through the complex airways of each individual patient, like a GPS system on your Google map, for example, to reach your target within the lung, even if it is very far away. So you can, once you reach there, you can use different tools. You can use needles, you can use graspers and biopsy forceps to get your diagnosis, to get your cells that you need for diagnostic tests. And also, you can also deposit things like a dye, a marking there for you to do surgery subsequently. As you know, introduction of every new technology requires significant risks, investment in time and effort with no guarantee of return. Nevertheless, Professor Thomas Gildea from Cleveland Clinic is credited for starting our program in Prince of Wales Hospital and indeed in Hong Kong. I promise that next time he visited, we'll have a wider selection of sizes of surgical scrubs for him. He was very confined in this particular photo. At that time, there was also a very senior thoracic surgeon in Taiwan, Professor Li Jiangming, who was interested in this technology, and we traveled together to several centers in the US to learn about this technology, ENB. But I found there was a problem with this bronchoscopic system. The GPS was not entirely accurate, and this happens with your phones as well, right? Not because of the technology necessarily, but because the lung is a constantly moving organ. A eureka moment came. We have recently installed a CT scanner in the operating room, in our hybrid operating room, and perhaps we can use this to improve the accuracy. So the idea was to use the GPS from the ENB on the left side. We get to where we think we should be, and then, like using a CT scan, like a satellite, take a photo to show that we are really there, that we are on that street in front of that shop. And if you're slightly out, the tumor is just on the opposite side of the street, you can always readjust the navigational bronchoscopy in order to get to your target. So this is the workflow that we propose using a navigational bronchoscopy system, subsequently doing a cone beam CT, a CT scan in the operating room, and hopefully you'll see an image like this where the tool is in your tumor, 100% sure, no doubt or argument about that. And it was such a revolutionary idea that we were immediately asked to produce workflow books and booklets and manuals to show others how this approach can work. But in fact, all over the world, there was only a handful, actually, of centers with this technology at that time, more than 10 years ago. Eventually, we did publish the first publication of combining this imaging technology with the ENB in order to get to our very peripheral small tumors to get diagnosis in EJCTS. And apart from being able to use the ENB for diagnostic purposes of biopsy, another important use is for localization of these small tumors during surgery. For example, how we might mark this very small lesion there on the bottom right that's seen on CT scan, and how we might find it during surgery. And how do we do it? Well, we use the navigational bronchoscopy, go through the airway to get to the nodule, and then we put a marker, we put some dye, some coloring next to that lesion. And during the surgery, we see the dye, and the dye also fluoresces, which is amazing. So you turn on the fluorescent camera, and it glows in your face, and you can just go and take it out very easily without any problems. So in terms of our progress using this endobronchial technology, in 2015, we performed Asia-Pacific's first hybrid operating room ENB. 2016, the first paper published using this technology, combined technology. In 2017, performed Asia-Pacific's first hybrid operating room dye marking for lung resection to localize these small tumors in a very accurate way. So I think these developments totally changed the landscape in managing these small lung tumors, and these were recognized by the patients we were now treating, and it's a paradigm change in thoracic surgery. We established ENB workshops in Hong Kong to allow more doctors to learn this technology, and were even attended by doctors from mega hospitals from Shanghai who have 20,000 cases of thoracic surgery a year to come and see how we might localize these small lesions. Our work and evidence helped define and shape some of the guidelines in managing small lung lesions or ground glass opacities. And with a number of publications in this topic and local data, EMB was finally granted Hospital Authority Hampson approval, allowing 11 other hospitals across Hong Kong, other than Prince of Wales Hospital, to acquire and use this technology. After those successes, interestingly, we were given another challenge by our patient. We kept on getting asked, once you navigated to the small tumor, doctor, that you can see there, can't you take it out using the bronchoscope so that I can avoid the surgery, the wounds, and having the pain? So that was a recurrent theme when we were telling patients that we can now localize your lesion and have surgery, but they don't want surgery. That's when we felt we should and potentially could do something in this uncharted territory. The idea that we can combine imaging, navigation, and ablation that can destroy a small tumor. So you can see here a 2mm microwave ablation catheter being used on a tissue block, creating a 3.5 by 4 cm ablation zone. So any tumor within that zone will be cooked and destroyed. And the idea is really to go down with the bronchoscope, navigate to your tumor that you can see on the left side, get to it without any issues, put this 2mm catheter into the tumor, and basically burn it. To combine the use of these technologies and to ensure safety and success, there was intense research and training that was required over a 4-month period, collecting significant air miles for me with 4 trips to the US that you can see there. And we did the first case in Asia Pacific of using hybrid operating room transbronchial microwave ablation for an 84-year-old who was not suitable for surgery and destroyed his cancer, and he went home the day after with no wounds and no pain. So you might ask, why weren't we the first in the world to perform EMB microwave ablation for lung tumors? We have to come back to this chap, Mr. Kelvin Lau. So he actually performed the world's first a few months before us in the UK. Nonetheless, we are very proud of him because he did receive training from CUHK. He is from Hong Kong, and he's also from DPS. So this novel technique of non-invasive bronchoscopic microablation was much needed approach that fills in the gap of totally avoiding trauma for our patients who have small, suitably located lung tumors. However, case selection is, of course, important for best outcomes. Tumors that are less than 2.5 centimeters in size are desirable, and tumors that are in the outer 2/3 of the lung are more desirable. Because we're using heat and being too central, you may burn big airways and big blood vessels. Nevertheless, compared with surgery, microwave ablation really has no access trauma, there are no wounds, there's no blood loss, and very few have pain. There's no scars, and the hospital stay is usually less than 24 hours. And the main thing is that we preserve lung function for these patients who may be very frail or have very poor lung function. We published our first paper after we built our experience and case numbers to 30 and showed really the world that this technique is feasible, it's technically safe, and also it has a reasonably early good outcome. And over the past 6.5 years since we started the endobronchial ablation program, we have become the most experienced team in the world in this technique, with over 258 cases performed, all successfully, and with minimal complications of 2 to 4%, 0 mortality for all these cases, and a recurrence rate of 8%. Certainly, as I get older, manually performing a navigational bronchoscope for hours on end become much less attractive. And new technology was again much needed. Robotic bronchoscopy was perhaps the answer. There are currently 3 systems that are FDA approved, and with support from CUHK, we currently have 2 systems out of the 3 in our hospital, and it's the only hospital in Hong Kong that has robotic bronchoscopy even up to now. So with robotic bronchoscopy, in fact, it has very good reach to the very peripheral parts of the lung, very accurate and very stable platform for you to do your diagnostic or your therapeutic procedures. And you can see here that it really is just like playing a computer game, and I have to say, junior members of my team are much better than me at this, picking this kind of technology up, because they are much better practiced at Xbox and Nintendo and so on. But you get the idea that you can reach lesions in the periphery very accurately. You can see here, this is a 1 centimeter mass lesion that's above the aortic arch that was turned down by all other specialties to get a biopsy. We drove this robotic bronchoscope up to the left upper lobe and around the aorta, basically, in order to get a diagnosis for this 1 centimeter lesion that was just sitting on the aortic arch, the biggest blood vessel in the whole body. We actually performed the first hybrid operating room robotic bronchoscopy procedure outside of the US. It was very new technology back in December 2021, and that was the Auris Monarch system. And the introduction of robotic bronchoscopy into Hong Kong was also voted one of the top 10 science technology news of 2022. Of course, we were behind that of Professor Dennis Low, otherwise I wouldn't have a job and wouldn't be standing here. And also, he's far more handsome, of course. The ultimate non-invasive weapon against small tumors is by combining robotic bronchoscopy with microwave ablation catheter. So it's combining the best of all worlds. And we performed the world's first robotic bronchoscopy microwave ablation of lung tumor on 24th October 2022. And you may be able to see some steam or some puff of smoke coming out from the vision you can see on the view on the right side, a direct vision from the robotic bronchoscope, and you see the bubbles as the tumor cooks, and you can monitor that as it proceeds with this treatment for these patients. We really believe that this is a game changer, as the combination of technology allows more accurate and precise ablation of lung tumors. The learning curve for doctors using robot is also much shorter, and they get to learn this approach much faster. We treated different patients, metastatic cancer patients to the lung, primary tumors to the lung. And this is an example of a tumor in the right lower lobe, shown in the red arrow. After the ablation, you get an area of destruction that's seen on the CT scan in the operating room that we can confirm. And by 1, 3, and then by 6 months CT scan, all of the inflammation resolves, and then the tumor debris is taken up by the patients, eaten up by the macrophages, and exchanged as fibroblasts as a scar. We now have a complete surgical armamentarium to manage all types and sizes of GGOs and lung tumors. From bringing out the big guns like single-port VATS major lung resection for large tumors, to medium guns like dye marking localization for wedge resection, to small invasive weapons like ablation to destroy all our enemies. This slide from a while back in the lecture, we now have a solution for patients coming to us with CT scans, such as these showing numerous lesions. We can give them a tailored treatment package. In fact, I believe we're not just providing a solution, as I said, but a personalized treatment, a tailored bespoke management package for each individual patient with multifocal disease of the lung. As every case is different, different size, different location, different numbers. We're providing patient choice for earlier treatment and to preserve their lung parenchyma and their function. So we have indeed been doing just that, as you can see in this workflow. We can bring a patient into the operating room and in a non-invasive way ablate small tumors. We can then, using the same technology, robotic bronchoscopy, dye mark medium-sized tumors to be resected, and then perform the larger resection for the bigger tumors. And all of them done in one general anesthetic session. Such one-stop, one-shop strategy in the hybrid operating room with all the tools allow patients with complex lung tumors to quickly have all their tumors treated in one go, while preserving as much lung function and tissue as possible for other further treatment. This one-stop approach to treat all tumors is associated with a high success rate, superb safety profile, and also with complication rate of just over 2% in our cohort of 103 cases that we have performed this kind of approach. And since our first transbronchial microwave ablation in 2019, this treatment approach has slowly been recognized by authoritative societies, including ISLC, and also more recently by the prestigious society, the American Society of Clinical Oncology, as well, in their newsletter. This is in part related to our publications that we have produced, for which I have my team to thank. To support all these endobronchial diagnostic and therapeutic developments, robotic bronchoscopy technology, research, etc., we are thankful for the more than 40 million we have received from grants, university, and industry just for supporting endobronchial diagnosis therapy. So endobronchial diagnosis, dye marking, and microwave ablation with robotic bronchoscopy seem to now complete the clinical needs and changing landscape of very small multiple lung tumors that we are facing. However, this is not the end. In fact, it is not even the beginning of the end, but is perhaps the end of the beginning, as Winston Churchill say. It's the tip of the iceberg. What you have just seen is actually just a small part of what we are trying to do. You may remember that microwave thermal ablation can only treat the outer two-thirds of the lung because of the heat it generates. How about the inner third? Non-thermal ablation approaches and immunogenic ablation approaches such as cryoablation using cold and electroporation are indeed currently being investigated that can treat the inner one-third of the lung. And some of these ablation technologies can have what's called an abscopal effect, which means that after treating the tumor in the lung with ablation, the therapeutic effect can be seen in other parts of the body where there is tumor. It activates the immune system of the patient. And many more forms of endobronchial ablation treatments are on the horizon, giving our patients hope. The green dots are those currently available or under recruiting for clinical trial at our center. The motivation and drive to continue to innovate and strive for better treatments often come from patients with special clinical needs. For example, Mr. Yao.
我今年75歲，並冇吸煙等等不良嘅習慣。而喺2017年初發現咗呢位肺部有好多陰影，檢查證實為多發性肺癌。過去嘅8年多嚟，感謝有吳教授同埋心胸外科團隊，我先後進行咗2次好成功嘅微創肺葉切除治療較大嘅肺癌。後來幸得吳教授引入咗經氣管引導微波消融手術，可以喺毫無傷口嘅情況下，將一啲慢慢惡化嘅磨砂玻璃腫瘤消融。每次做完微波消融手術後，從麻醉醒返，身體都冇咩嘅痛。到咗第2日，便感覺同正常情況冇咩大分別，可以出院。不過，自從確診肺癌已經有8年幾，喺我患病期間，我同家人都可以樂觀過活，不見哀愁。每朝打開眼睛都感恩有一天。
Or your patients can be those very close to you, or those you have an immense lifelong impact, like colleagues or even medical students.
大家好，喺作為醫學生嘅過程入邊，最令我印象深刻一定係母親嘅患病經歷。當時嘅我面對自己屋企人嘅病痛，都覺得好無助。好彩我哋遇上咗吳教授同佢哋嘅團隊，同埋好好嘅腫瘤科團隊。佢哋用嶄新嘅技術醫好咗我母親，令到佢重獲新生。喺呢度好多謝佢哋。咁多年過去，我已經成為一個實習醫生，更加明白到呢個醫生嘅工作同使命。我希望將來可以成為一個好醫生，以吳教授同佢哋嘅團隊作為榜樣。除咗日常平時繁忙嘅臨床工作以外，都花好多自己嘅空餘時間去投入科研，去帶領醫療技術嘅發展。科學文獻上面嘅每一個數目字，代表其每一個病人同家庭嘅希望。好慶幸我而家仲可以有一個完整嘅家庭。都希望更多嘅病人可以好似我母親一樣戰勝病魔。多謝大家。
With the Environmental Foundation, founded by Dr. CUHK, the establishment of this professorship and generous donation, we shall continue our innovative and impactful work to seek better treatment options for our patients who may have lost hope and to give them a new beginning. What you have heard today, I hope I have convinced you our development strategies of finding solutions in areas of unmet need in the thoracic surgery landscape is in line with Seung Sin Yuk-sui principles and philosophy. As I come towards the end of my lecture, I wish to thank everyone who has been part of my life. Firstly, Vice-Chancellor Professor Dennis Low, Dean Chiu, and all my seniors and colleagues in the university community, as well as research partners who have given me opportunities and support over the decades. My hospital community, colleagues and team, secretarial staff, who've been instrumental in keeping everything running and treating the patients. My global community of friends, many have traveled long distances today, just even for a day, to come and support me, and I thank you from the bottom of my heart. Friends from industry, many in the audience today have supported me for decades, and we have really lasting friendships. The Hong Kong community I wish to thank, and also the patients in their belief and the trust in us, in CUHK and Prince Wales Hospital, and medical students to provide us with hope for the future. Last but not least, my special thanks to my beautiful wife and kids for tolerating me and the schedules that I have. Professor Melfi was the first to perform robotic lobectomy for lung cancer back in 2001. I just want to finish by quoting her. Innovation requires courage to challenge established norms and to open doors for new insights, techniques, and technology. And with that, may I thank every one of you again who have been part of my life, who I am today. Thank you all for your attending this lecture.
Thank you, Professor Ng, for your inspiring and insightful lecture. May I invite you to join the audience in the front row for one final group photo. Thank you, everyone. Ladies and gentlemen, that concludes the inaugural lecture. Please rise for the exit of the official procession.